Hello, and welcome to Wally's Nursing Videos. Today we will discuss the pathophysiology of acute kidney injury, as well as the processes involved. Acute kidney injury, AKI, is the sudden loss of kidney function, impairing the kidney's ability to filter waste, regulate electrolytes, and maintain fluid balance. AKI is categorized into three types: prerenal, intrarenal, intrinsic, and postrenal, based on where the problem originates. Each type requires prompt recognition and intervention to prevent progression and improve outcomes. This lecture will walk through the pathophysiology of AKI using a process map, while also covering assessments, diagnostic findings, and nursing interventions for each AKI type. 1. Prerenal AKI definition. Prerenal AKI occurs due to decreased blood flow, perfusion, to the kidneys. The kidneys are structurally intact but cannot function due to reduced perfusion. Causes: hypovolemia, e.g., dehydration, hemorrhage, burns; low cardiac output, e.g., heart failure, myocardial infarction; systemic vasodilation, e.g., sepsis, liver failure; renal artery stenosis. Psychophysiological process map. Initial stimulus: low blood volume or low blood pressure leads to reduced renal perfusion. Kidney response: activation of the renin-angiotensin-aldosterone system, RAAS, to increase blood pressure via vasoconstriction and sodium water retention. Increased antidiuretic hormone, ADH, to conserve water. Compensation: temporary improvement in perfusion, but if sustained, hypoperfusion leads to ischemic injury. Prolonged hypoperfusion: reduced glomerular filtration rate, GFR, leading to increased waste accumulation, elevated BUN and creatinine. If untreated, ischemic injury can progress to intrarenal AKI. Assessment and diagnostic findings. Vital signs: hypotension, tachycardia, orthostatic hypotension. Physical exam: signs of dehydration, dry mucous membranes, poor skin turgor, or fluid overload, dependent edema in heart failure. Laboratory findings: elevated BUN creatinine ratio greater than 20:1, indicating prerenal cause; decreased urine sodium concentration less than 20 mg/L; concentrated urine, specific gravity greater than 1.020; low fractional excretion of sodium, FeNA less than 1%; urine output, oliguria, urine output less than 400 ml/day. Nursing interventions: restore perfusion. Administer intravenous fluids, isotonic fluids like normal saline, to increase circulating volume. If heart failure is present, administer diuretics as prescribed to reduce fluid overload. Monitor vital signs in I and O. Regularly assess blood pressure, heart rate, and urine output to evaluate response to fluids. Maintain strict input and output records. Manage underlying causes. Treat underlying conditions like dehydration or heart failure. In septic patients, administer antibiotics and vasopressors as ordered. Collaborate with healthcare team. Work with physicians for additional interventions like blood transfusion for hemorrhage or medications to support blood pressure. 2. Intrarenal intrinsic AKI definition. Intrarenal AKI results from direct injury to the kidney's internal structures, glomeruli, tubules, or interstitial tissue. The most common causes include acute tubular necrosis, ATN, from ischemia or toxins, glomerulonephritis, or nephrotoxic medications. Causes: acute tubular necrosis, ATN, ischemia or nephrotoxins such as NSAIDs, aminoglycosides; glomerulonephritis, inflammation of the glomeruli; acute interstitial nephritis, allergic reaction to medications; vascular disorders, e.g., vasculitis. Psychophysiological process map. Initial stimulus: direct damage to kidney structures, e.g., from ischemia or nephrotoxins. Kidney response: inflammatory response leads to tubular cell damage and sloughing, causing obstructions in the nephrons. Reduced GFR due to tubular obstruction and impaired filtration. Systemic effects: accumulation of waste products, creatinine, urea, and electrolyte imbalances, e.g., hyperkalemia, metabolic acidosis. Potential recovery: if injury is mild and reversible, Kidney function can improve with appropriate interventions. Severe or prolonged injury may lead to chronic kidney disease. Assessment and diagnostic findings. Physical exam. Signs of fluid overload, peripheral edema, pulmonary crackles, uremic symptoms, confusion, nausea. Laboratory findings. BUN and creatinine both elevated, with a normal BUN-creatinine ratio, 10 to 20 to 1. Increased urine sodium concentration, greater than 40 MEq/L, dilute urine, specific gravity less than 1.0110. Fractional excretion of sodium, FeNA greater than 2%, urine microscopy. Granular or muddy brown casts indicating ATN, or red blood cell casts in glomerulonephritis. Electrolytes, hyperkalemia, metabolic acidosis, nursing interventions. Identify and remove causative agents. Discontinue nephrotoxic drugs, e.g. NSAIDs, aminoglycosides. Manage glomerulonephritis with steroids or immunosuppressive therapy as prescribed. Fluid management. Carefully balance fluid administration, avoiding fluid overload while maintaining renal perfusion. Administer diuretics only if needed to manage fluid balance. Monitor for complications. Monitor electrolyte levels closely, especially potassium. Administer sodium bicarbonate or calcium gluconate if hyperkalemia is severe. Watch for metabolic acidosis and provide bicarbonate therapy if indicated. Patient education. Educate patients on avoiding nephrotoxic substances. Encourage dietary modifications for electrolyte management. 3. Postrenal AKI definition. Postrenal AKI occurs due to a blockage in the urinary system that prevents urine from being excreted. This leads to increased pressure in the renal system, causing damage to the kidneys over time. Causes: ureteral obstruction, e.g. to kidney stones, tumors. Bladder outlet obstruction, e.g. benign prostatic hyperplasia, BPH. Neurogenic bladder. Urethral obstruction, e.g. strictures, trauma. Psychophysiological process map. Initial stimulus. Obstruction leads to a buildup of urine in the renal pelvis and ureters, increasing pressure in the nephron. Kidney response. High pressure impairs the glomerular filtration process, reducing GFR. Over time, ischemia occurs, damaging renal tissue. Systemic effects. Accumulation of nitrogenous wastes and electrolyte imbalances due to impaired excretion. Relief of obstruction. Prompt removal of the obstruction allows kidney function to recover. Delayed intervention can lead to permanent renal damage. Assessment and diagnostic findings. Physical exam. Flank pain, lower abdominal pain, or distended bladder. Patients with BPH may have difficulty initiating urination. Laboratory findings. Elevated BUN and creatinine with a BUN-creatinine ratio similar to intrarenal AKI, 10 to 21. Post-obstructive diuresis may occur after relief of the obstruction. Imaging, renal ultrasound to identify hydronephrosis or bladder distension. CT scan for further evaluation of obstructions. Nursing interventions. Relieve the obstruction. Insert a Foley catheter to drain the bladder if bladder outlet obstruction is suspected. If ureteral obstruction is present, prepare the patient for procedures like lithotripsy or stent placement. Monitor for post-obstructive diuresis. After relieving the obstruction, monitor for excessive diuresis, which can lead to dehydration and electrolyte imbalances. Replace fluids and electrolytes as needed. Pain management. Administer analgesics for pain control, particularly if the patient has renal colic due to stones. Patient education. Educate patients on lifestyle changes to prevent recurrence, such as increasing hydration and dietary modifications to avoid kidney stones. Conclusion in managing AKI: timely identification and differentiation between prerenal, intrarenal, and postrenal causes are critical. Early recognition of assessment and diagnostic findings, followed by prompt nursing interventions, can prevent the progression to chronic kidney disease and improve patient outcomes.